Hey folks, welcome to the AABIP podcast. This is Samir Avasarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm your host for this episode. Thank you for joining us. Today we'll talk about using ECMO to facilitate high-risk bronchoscopy. I'm thrilled to have Dr. Aline Zouk join us. Aline is an assistant professor of medicine at the University of Alabama in Birmingham and the associate program director of UAB's IP fellowship. Aline, do you have any relevant conflict of interest to disclose?
I do not.
All right. As a reminder, the views expressed on this podcast are those of the speaker in mind and not necessarily endorsed by the AABIP. With the formalities done, let's get started. Severe respiratory failure with central airway disease is a dangerous combination. Therapeutic bronchoscopy relieves obstruction and improves the patient's clinical status. However, therapeutic bronchoscopy in the setting of severe respiratory failure, at times, that's risky business. In some instances, ECMO support can be used to help facilitate these cases. Let's hear more about this unique scenario from our expert. Aline, what specific scenarios come to mind when considering ECMO support to facilitate a therapeutic bronchoscopy?
Thanks, Samir. I just want to start off by thanking you for having me here, and I'm happy to talk through this very difficult and often daunting situation. I tend to think about ECMO in any situation where there's a significant concern for the loss of the ability to ventilate or oxygenate during a bronchoscopy. The most common scenario that comes to mind usually is, as you alluded to, severe central airway obstruction, particularly with tracheal obstructions where muscle paralysis can often lead to the loss of a patent but already narrowed airway. When we generally think about airway obstruction, we tend to think about only the malignant disease, but there have been also some cases reported in the literature where ECMO was used to support bronchoscopy for stent placement in like severe tracheal bronchomalacia or severe tracheal stenosis. We also had one patient at UAB with refractory hypoxic respiratory failure due to postpartum PAP. We placed her on ECMO and she tolerated the whole lung lavage that was needed to resolve her respiratory failure and liberate her from the ventilator as well. Other things that come to mind, there's been some cases reported in the literature where ECMO was used to support patients that had highly vascular tumors, like when we think about carcinoids or schwannomas, particularly if they're in the distal trachea and they're more prone to bleeding during these interventions. I do think, though, that there has to be some careful thought, especially with the bleeding tendencies when we're exploring these options, because we want to reserve these strategies for patients with a very significant risk for the loss of airway and ventilation and not just for the potential of bleeding.
Yeah, absolutely. So I'm glad you brought those things up. So when you're seeing these patients and you're kind of making this decision, are there any specific things you kind of keep in mind in the pre-procedure evaluation about, hey, should I put this patient on ECMO? And two, what else should I kind of keep in mind to make sure they're going to get through this safely because they're going to be on a circuit?
Yeah, that's an excellent question. And I think the generic first starting off is really the pre-procedural evaluation should be similar to any procedure that you do, whether bronchoscopy or any other intervention. So assessing the risks, the benefits, the alternatives, the contraindications, particularly when it comes to bleeding risk, because these patients are often given some form of heparin. In patients who are severely symptomatic, you can start off by giving Heliox, the mixture of helium and oxygen that you can use to bridge and alleviate some of these symptoms. So you can, while you're trying to get bronchoscopy set up, while you're trying to have your discussions with your anesthesiologist or your ECMO team. In particular to this specific topic, what we're talking about, you have to also think about the type of ECMO you're using. Should you be using VV ECMO or VA ECMO, particularly in those patients who have maybe heart failure or hemodynamic instability? And then the strategy that you're going to use. Are you cannulating for ECMO or are you just having ECMO on standby? Those are all things that we're thinking about while we're evaluating for our procedure.
I'm glad you brought up the cannulation aspect of it. So what is your approach? Do you pre-cannulate if you know this patient's going to need it? Yeah, well, let's just get it done, or the wires are placed and then everyone's kind of on standby and then you kind of make a decision as the case goes on.
Well, there really isn't a typical strategy for these cases because they're so rare and they happen pretty sporadically. And the strategy to take, there's multiple strategies. So whether to keep ECMO on standby and available in the room only if you need it, or place introducer wires for potential cannulation, or just pre-cannulate and start ECMO prior to the procedure, that's decided on a case-by-case basis, particularly after discussions with surgeons that are cannulating for ECMO, and is usually also based on the patient's current clinical condition. Are they going to be able to lay flat? Are they going to, for the cannulation, are they going to need some form of reclining that will prevent them from getting cannulated right away? And the level of the presumed risk of the airway loss during the procedure as well. I think
Go
all
ahead,
of
I'm
those
sorry.
things take into consideration. No, that's okay. I think we take all those things into consideration, and after discussions with the surgeon, that's really where we make that decision.
What's the setup at your shop with IP? I'm presuming cardiothoracic anesthesiology and a surgical or potentially interventional cardiology team involved?
Cardiac surgeon, CV anesthesiologist is usually involved, and the interventional pulmonary team. That's correct.
Okay. So with cases that you've done after, let's imagine you defined an endpoint, it's successful. What's your usual plan for weaning the patient off ECMO? Do you have them tolerate a zero sweep gas for, I don't know, let's say 10 to 15 minutes or some other strategy?
It really depends on what you intend to do, and we try to leave the weaning strategy up to the surgeons. Mm-hmm. The goal here is really to just keep ECMO running for as shortest of a time as possible, and to decannulate. What we would love to do is decannulate every patient in the OR room or immediately post-op once they get to the unit. The consideration here is if there's a potential for repeated interventions, that's when we may decide to keep the patient on ECMO for a day or two until we come back and if we have to do some form of repeated intervention, like repositioning a stent or going in to remove a clot or something of the sort, we'll try to keep that. But in general, the motto is to try to keep ECMO running as short as possible. We do leave the strategy up to the surgeons. That's in their field.
Got it. Makes sense. So with ECMO, although it's not an organ transplant, I define it. It's a very finite resource. It's a limited resource for a variety of reasons. Have you come across any cases that you've done through your career that you thought, I wish I would have put that patient on ECMO, or any particular scenarios come to mind that you wish you could have done it, but just didn't pull the trigger up front?
I actually have the opposite experience. So there is one particular case that comes to mind where I wish we potentially haven't had put the patient on ECMO. It's a difficult situation. I think, we always have to have those ethical considerations that we think about when we're thinking about life-saving procedures. And I think patient harm can sometimes be one that we miss. So I haven't really had any patients where I had wished to put them on ECMO, but I can think of, one patient that, one of the first patients that I put on ECMO that had a critical tracheal compression and a new diagnosis of small cell. We placed her on ECMO to help support the rigid bronchoscopy and stent placement. After the procedure, she had recurring issues with her mucus plugging and the ECMO team felt like she was not ready to come off ECMO. But unfortunately, this delayed her treatment plans for radiation and for chemo. There was a lot of discomfort towards sort of treating someone on ECMO, whether it was the logistics of radiation or the pharmacokinetics of chemo with someone on ECMO, and her disease sort of rapidly progressed, ultimately leading to goals of care conversation and withdrawal of care. In the grand scheme of things, I think this might not have mattered, but I can't help but wonder whether she would have had a different outcome had she not been cannulated for ECMO. I think here in this situation, the communication fell through with the involved teams, and perhaps a clearer and more strict plan for ECMO weaning, like we were talking about, and removal maybe could have changed things here.
That sounds like a very complex situation with
Yeah.
a lot of decisions that had to be made in a quick amount of time to help the patient out.
Yeah.
I'm going to pivot here a little bit with ECMO, and since you're the APD for an IP fellowship, do you think fellows should get exposed to more cases with ECMO support, or do you feel like it's going to end up being like an unnecessary parachute that's going to take away from therapeutic rigid bronchoscopy skills?
No, absolutely. I think it's always a balance with everything that we do. There's a reason to be exposed because that will open up your mind to and open up sort of your way of thinking about what you can do with patients, especially fellows who might be going to work in more academic centers where they have the ability to put patients on ECMO. It's important to understand that ECMO, it has become widely available, but it's still not free of risk. And I think that's what we should be teaching our fellows as well, that while we can use it for those patients that have severe critical airways and a substantial potential for fatal airway loss,
Mm-hmm.
it's not to be used for everyone because the risks are still there and the benefits should really be really weighed carefully. This is still non-traditional. This is still not something I think that will pick up and become for every rigid bronchoscopy that we do. And I think the practice that most of us have are such that we'll be teaching our fellows to really be careful in considering who you pick for ECMO supported bronchoscopies.
Yeah, I think it's just another tool to keep in mind that we have
Exactly.
the option to use it, but a majority of the cases will probably not need its services.
Absolutely.
You touched upon ethical considerations, and I'd like to talk about a slightly different aspect of that. So let's say you have a patient that you had cannulated for, let's just say, malignant central airway obstruction, and for some reason, technical success seems unlikely, and you've already started the procedure. How long do you keep the patient on ECMO support? Do you have conversations ahead of time with specific consent to kind of have a predetermined plan of how long you're going to give this a shot before saying, hey, this is as far as we can push it here?
Yeah, that's a great question. And as with all my other answers, the situation is really truly on a case by case basis. But I think you touched on something really important, is having those thorough discussions with the treating teams and the ECMO team, and specifically the patient and the family as well. We always talk to the families about trying to minimize the time on ECMO, but should there be any reason why we think that there is no technical success, we'll try to have a clear plan moving forward, whether that's a few days, whether that's a week. It really just depends, I think, on the patient's clinical status as well and why we're doing the procedure in the first place. There's no real one cookie cutter answer for that.
It sounds like the rest of IP, huh?
Exactly. That's why we love it.
Absolutely, absolutely. So, I think it's fascinating to just take a step back and look at the application of ECMO in this particular scenario. Years ago, decade, if not two decades, considering ECMO for someone with malignancy would have put some pause. And now we're talking about putting patients on, albeit for a shorter term, to facilitate procedures being done, knowing that they have malignancy. So I think that evolution and the evolution of viewpoint is just fascinating, and it'll be interesting to see how things go over the next few years. So, time for closing remarks. Anything we left out that you felt that's important to discuss?
I think we had a pretty good summary. I think it's just really important to remember, like you were saying, that this is relatively new still. There's no strong evidence in the literature for the use of ECMO and supporting high-risk bronchoscopies. And really, all of the information that we have is limited to case reports and case series. Although this has shown some technical success, I think there still needs to be a lot more before we use this routinely, like you were talking about. And then the most important point to hammer home is the multidisciplinary approach. Really, these cases need excellent communication with the ECMO teams, your anesthesiologists, your oncologists, and most importantly, the patient and their family, to give them realistic expectations of what the worst case scenario can be and what the best case scenario can be. That's truly, I think, critical for success in these very often complicated and nuanced cases that we dread, but at the same time can be so gratifying as well.
Absolutely. Aline, this was wonderful. I and our listeners appreciate your time. Thank you.
Absolutely. Thank you. It was a pleasure.